is utilization of vital signs. Unfortunately, in our practice of medicine in this country, we don't do that as often as we should. We somehow overlook the critical aspects of the vital signs, and we try to directly move into clinical symptoms. Often, that doesn't guide us to the right direction. One thing that I want to emphasize today, every clinical scenario, every clinical scenario starts with an assessment of vital signs. Vital signs gives you the beginning of the information that you need to unfold your case. No clinical decision could be safe and sound without assessment of vitals. And a complete vital signs is just not blood pressure and heart rate and O2 set. A complete vital signs contains blood pressure, heart rate, O2 set, respiratory rate, GCS, body temperature, and often in North America, they believe that BMI is part of the vital signs. I do that for every patient of mine. I make sure that I have all this information before I could move on to ask them why they have come to my clinic. Get to the habit. You treat several dozen patients until you run into somebody whose vitals are not stable. That person would not be properly assessed without fully appreciating their vital signs. So once again, I emphasize assessment of the vital signs in every clinical scenario. Now, the second concept in rational clinical thinking, often we get so drowned in the data, in the medical data, we lose our common sense. We lose our ability to see the forest because we are so focused on a single tree. Often, my instructors back in the days in the med school, in residency training, they would always tell us, do not forget about the forest. Don't just focus on the tree. I give you an example, and I back up all these clinical scenarios with the scenarios that I will be mentioning. 19 years old female presents to a tertiary care center with cough and shortness of breath. So remember, 19 years old with cough and shortness of breath. The caveat was that she was also 7 months pregnant. She had had 5 previous presentations for the same clinical symptoms. She had been given bronchodilators and antibiotics of many different kinds. Now, for the 6th time, she's coming back to the tertiary care center with cough and shortness of breath. There is no complete assessment of the vitals because they do not believe in its importance. Often they fill out the sheets with some information that is not accurate. Often they do not measure the blood pressure properly. They do not count the respiratory rate. If they have O2 sat monitors, they may monitor the sat. So very incomplete set of vitals are there. Now, I want to hear from you. What would you do? I will tell you the vitals that they have assessed. The patient's blood pressure, it's 105/65. Her respiratory rate is 32. Her O2 sat is 87. The body temperature is not measured. The GCS is not measured. The BMI is not measured. So now you're at the triage points with these incomplete vitals. What would you do? How would you approach? Examine your rational clinical science.
Dr. Azer, can you please repeat the vitals one more time? Thank you.
Blood pressure is 105 over 65. The heart rate, it's been said it's 120. The O2 sat is 87. The respiratory rate is 32. This is your vitals. GCS is unknown. BMI is unknown. Body temperature is unknown. And you want to approach this case. And you want to examine your rational clinical thinking. What are you thinking? What does the rationality tell you here?
Colleagues, please, everyone who wants to speak can please open your microphone and talk to us. Dr. Nematullah, can you hear me? Dr. Arbobzadeh is asking, how can it be possible without vital signs?
While we have vital signs, I want us to examine navigation. Right now, you have a 19 years old female. She's 7 months pregnant, coming with shortness of breath and cough of several weeks duration. She has seen physicians 5 times. She's coming to a tertiary care center for the 6th time. These are the vitals that are documented on the chart. Now, I want to know, when you look at this clinical scenario, how would you navigate? What does your rational clinical thinking tell you? What should you do?
Uh,
How would you
may I?
rate these vitals? How do you incorporate them? How do you comprehend them? How do you take them to the next step? This is the process of rational clinical thinking. Every step should help you to navigate and identify your next clinical step.
Dr. Azar, may I?
Yes, please.
Um, so I want to start with the age group of the patient and she being pregnant and the time frame of the symptoms. Considering that the symptoms are somewhat chronic, as you said, it's been more than a few weeks, I guess. Am I right?
She has had almost 6 weeks of these clinical symptoms.
Okay. If it's chronic, I'm thinking of processes that can chronically cause these symptoms. If I'm gonna go to a approach for dyspnea, the thing is, it can be categorized as hematologic, cardiac, or respiratory. I start with the cardiac first. In the cardiac, I don't know many problems that can act for 6 weeks and afterwards can also bring the patient to this situation that we are facing now. Maybe in the carditis, but in the lack of the, for example, fever or some other symptoms, it's unlikely. Or maybe some abnormal cardiac problems that has been exacerbating during this pregnancy. Um, in the context of the respiratory system, I will be thinking of more chronic ones. Um, But in a
But
19-year-old,
Ahmad, I need to challenge you on that, and I think
please go.
Tarani is following this discussion. But this is a clear example of rational clinical thinking going wrong. Right now, is that the diagnosis the most important or the stabilization?
The stabilization for sure.
Now, sometimes stabilization and diagnosis go hand in hand, but often they don't. When I look at this clinical picture, Tarana mentions respiratory gate is open. The next immediate question in a rational clinical thinking, is there any gates of death which are open? Do I have enough information to assess if the gates of death are open or not? Respiratory gate clearly is open. If I tell you her mentation is impaired, if I tell you her GCS is 13, would that contribute to this clinical picture? If I tell you body temperature is 40, would that contribute to this clinical picture? Yes, it does. So rational clinical thinking means getting all the information to make the first assessment to see if this patient is in the arms of death or not. Do I make sense? This is why vital signs are critical, because you make an assessment into the process of how close this patient is to die, because that determines your triage, that determines your first immediate step. Now, remember this, we are going to follow the case, but today, somebody today at about 3 o'clock came to my clinic with left upper quadrant pain, 45 years old male with left upper quadrant and flank pain. All right.
Right.
What would you do? What would you do? How would you approach that? How would you approach that? I need one of you guys to step in. Jump on the trap. Go ahead. Give me your thoughts.
Miss Zare is asking about the vital signs of the patient.
Absolutely. 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 Often we wouldn't do that. We go to an ultrasound imaging and a lab work or abdominal exam. But no, no, don't ever do that. I examined this guy. His blood pressure is 240 over 150. 240 over 150. Heart rate is 106. O2 set 92. BMI 34. Now, do I have opportunity to send this guy for imaging? Am I going to send this guy for a lab work? This is most likely an acute coronary syndrome with referred pain. I put her on cardiac monitor. Clearly, there is T wave inversion and ST depression in anterior leaves. So please, do not take the situation for granted. Do not believe you have seen enough that you don't have to go through the proper pathways. It's like those drivers that they think they are great drivers, so they don't need to obey the law. They could drive anywhere that they want. No, don't do that. Now, with this female, 19 years old, 7 months pregnant, I look at these vitals. The gates of death are open, the vitals are incomplete. The first immediate step, I need a complete vital. if I can achieve them. When they relate this information to me, I immediately ask for body temperature and for GCS. And I ask questions that could shed light on this clinical picture first before I could go further. If I have a chance, she cannot speak in full sentences. The GCS is 13. The body temperature is 40. The gates of death are open here. She could get into respiratory arrest any moment. As the time is unfolding, I asked for reassessment of the blood pressure. Now, blood pressure is 92 over 60. You are losing pressure. Now, tell me what you would do. Let's shed light on clinical navigation. You are in front of this patient. What does your common sense tell you? What could we do?
By the way, let's say hello to Dr. Mojibian. She's on it now.
Greetings, Dr. Mujibian.
Okay. Ms. Arabzadeh said pro-oxygenation. I think she mentions the ABCD approach for the stabilization.
Tell me specifically what you want, because we could memorize ABCD, but we need a clear mental image of every single one of them, what they mean. What would you do with this 19 years old female? What would you do? Pre-oxygenate, I agree. We gave her a face mask. We give her free-floating oxygen, non-rebreather. Next. What's next?
Dr. Arabzadeh, can you hear us?
Yes, of course.
So,
Hello, Dr. Azer.
please.
Greetings, Dr. Babzadeh. I hope you are well.
Thanks a bunch, Professor. Yes, I think, as you mentioned, the gate of the respiratory and CNS is open, and the first step is stabilization. At first, pre-oxygenation with mask is the preferred um, item. And then if we are not sure that the support of upper airway is adequate or respiratory protection support is not adequate, we should manage the airway with intubation.
Often we lose patience in that very specific step. These are the time that rational clinical thinking, the common sense medicine. This patient is conscious. She has a GCS of 12, 13. The mentation is coming down. We are not sure he's protecting his airways. I agree. He cannot speak in full sentences. Her O2 sat is low. His blood pressure is low. If I sedate this patient, what should I use? What guarantee is there that this patient would not code under sedation? Is there a sedation that would not cost you blood pressure? No, there isn't. Even 2 milligrams of midazolam is enough to collapse that blood pressure. So tell me exactly what we should do. I agree. We put the face mask on. O2 set has come to 89, 90, not more than that. The blood pressure every time they measure it is a bit lower. From 105, it has come to 95, and now every 2 minutes I have told them measure the blood pressure. Now the blood pressure is 85. Systolically, diastolically is 50. You are losing pressure.
So doctors are, um, if I were in that situation, I would seriously consider to hemodynamically establish patient via the C part, the circulation part. I would raise the leg to divert more blood through the central part of the body, and
We
also
did that.
I would.
We did that. O2 sat came down. Blood pressure got
Okay,
worse. Blood pressure is 75 now with raising the legs.
so uh, if we raise the legs and this sickle happens, I would think an obstruction maybe in the blood flow, such as something like pulmonary embolism, such like this. And in this situation, giving more fluid will worsen the situation of the patient. So I will not add fluid for this patient, administer fluid for this patient, but I should find a way to actually fix the circulation problem uh, with this
What is that
clinical
finding the way?
scenario.
What is the way? What is the way? What would you do?
Exactly. With this clinical scenario, I think there might be a obstruction in the path of the circulation. Maybe I move forward to administer something to uh, destroy this obstruction that is presumably something like an emboli. I maybe
All right.
start.
So, well, it's too premature to jump into that conclusion, but I need you to think. Patient is in front of you. This is the vitals. Do you know what you are doing? Pre-oxygenate, I agree. It doesn't cost us much. Raising the legs doesn't help, makes it worse. What would you do? Where is the common sense? Do you have enough information to make a clinical judgment?
I don't think so.
Have you guys examined this patient?
Not yet.
Why not? Where is the rationality here? I come to a clinical scene, 19 years old, 7 months pregnant, 6 weeks cough and shortness of breath, deranged vitals, unstable, complete vitals, given, time is not helping. Situation, clinical scenario is getting worse. I don't know what to do. I need more information. This more information comes from observation, from assessment, from physical exam, and at times, lab work, imaging. Rationality means this. Rationality means I am going to the kitchen. I want to cook. I need a pot. I need a stove. I need cooking equipments. I need food items. The same way that cooking comes and flows with you, clinical scenarios should flow with you. You should think what is missing, where is it missing? For whatever reason, this woman does not respond properly to volume. Giving volume is not an option. Cardiac gate is getting open. The heart rate is increasing, the blood pressure is going down. I need to know what is going on here without risking too much. Putting a central line right now at this very moment is critical. By putting a catheter in the right heart, several goals would be achieved. Number one, volume status. two, forward flow obstruction if it's obstructed. Number two, introduction of vasoactive medications. And as I mentioned, physical exam is absolutely essential in a rational approach to your case. I tell you what we find in her physical exam. BMI is low. BMI is 17. So keep this in mind. The heart sounds are muffled. They are very soft. You barely can hear them. There is upper lung crackles bilaterally and bibasilar crackles. The lower extremities have significant edema, pitting edema, but they're identical. One side is not the bigger than the other. The JVP is approximately 16 centimeters above sternal angle. The cardiac apex is not palpable. What would you do?
Those are, I think, uh, in this situation with this presentation of the physical exam that you mentioned, um, there is a classic triad of something like tamponade, I think. And in this situation, exactly, and especially considering that the pitting edema and the chronicity of the patient's situation, we can think of something like chronic um, um, pericardial effusion that now is pushing hard to the tamponade, something like this.
I agree, but is that the question? Right now, the most pressing question is the diagnosis or intervention. And this
Uh,
is
in this
navigation.
in this situation, I guess the diagnosis is a key to proper intervention because if we want to relieve the pressure on the heart, we can get some fluid out of the precardial space so the heart can beat properly again.
Okay, this is all about the challenges. Now, we have a central line in. We are monitoring the right heart. She's on a cardiac monitor. The respiratory reserve is being lost. She's getting tired of breathing. Her respiratory rate now is 42. VO2 set is coming to low 80s, 84. What should we do? The GCS is going down. She's barely conscious.
Guys, anyone wants to take the challenge other than me? Okay. In this situation, I would call for intubation setup to be ready. So if the patient loses um, more GCS points or gets to a situation that is respiratory compromised, I can immediately intubate her.
The reason that I need you to challenge your minds, I need you to imagine yourself in that clinical scenario. I need you to learn how to walk on eggshells without breaking them. Because it is often these kind of situations that the eggs break and the person dies.
Mm-hmm.
The GCS is going down, the O2 sat is coming down, the oxygenation is not responding, ready for intubation with positive airway pressure. What would happen to her cardiac situation? If I intubate her and I put her on a ventilator, what would happen to her heart?
I presume it would be worse for her.
What does intubation do to the blood return to the heart?
I guess, especially with positive and respiratory pressure into ventilation, the pressure that is imposed to the pulmonary system causes the pulmonary resistance to go higher, I guess, and this is kind of more block in the circulation of blood to the heart.
So this is where again, let's do that rational thing. You are breathing in with a negative pressure of 2 to 4 centimeters. Am I right? When the diaphragm flattens, it creates a negative pressure of 2 to 4 centimeters. That's the pressure that brings the air in and pulls back the blood from the venous pool. When I intubate you and I give you a PEEP of 8, the blood return to the right heart is compromised. It's not going to return as good as it would have been under 2 centimeters of pressure. Now, if you are right and this is cardiac tamponade, and if you lose your preload, what happens to your heart?
Arrest.
Would it collapse under the pressure from pericardium? Yes, it would. Then without stabilizing the heart, intubation would cause this patient an arrest. Rational clinical thinking means calculation before you get yourself in deep trouble. Asking yourself, if I do this, what would happen? Now that we have a central line, what about giving a vasopressor? What about trying to belt on the blood pressure, bring it a bit higher up, giving him a vasoconstriction, making the heart to pump a bit profoundly, a bit stronger. This is a 19 years old heart. And if you strongly suspect pericardial effusion and pericardial tamponade, what about an intervention that would relieve some of that? Now, in every step of the way you think loudly. If you put a pericardial drain and you drain a liter of fluid away, what would happen to that heart? It was pumping with a preload of 30 cc's. Now the pressure from the surrounding area is released. Now it could take 70, 80 cc's, which it doesn't have. So the heart is bigger. There is a little volume in it. What happens to forward flow? You lose forward flow. These are the clinical scenarios that you hear from your colleague. All of a sudden, the patient arrested. No, no. Nobody all of a sudden arrests. You took steps that were not calculated. You did things that you did not know how they are going to cause potential harm. Rational clinical critical thinking means walking on eggshells and not breaking them, of being so mindful of the overall clinical scenario without causing a patient's death, resuscitating them and bringing them out of this gate of instability. Do I make sense?
Yes, of course.
Anybody else is there, or is it just me and Ahmed Reza?
I'm here, Dr. Azar. We're listening to you.
Okay, well, I should send a salawat for the first time I hear you guys' voice. Can you guys speak for God's
Happy
sake? I
to
mean,
see you. Sure. I'm sorry, but I had something to do and it took too late. Sorry. I'm really sorry for not attending on time, but I was listening to you and I was using the information. It was really vital information about what we should do in such scenarios, and I'm
I will
still
give you the
listening. I'm
30
taking
words, but
notes.
first fix the Dr. Mojibian's voice. I told you guys,
Yeah.
every session, one of you guys should be with her because she's never trouble
Really?
free. Never, ever.
Oh,
Fix the
that's
voice
great.
for her, please.
I will. I will as soon as possible. Sorry.
Now, 30 words. 19 years old female, 7 months pregnant, presenting with 6 weeks of cough and shortness of breath. Has been given numerous antibiotics and bronchodilators to no effect. She's coming back to a tertiary care center with unstable vitals. Blood pressure is going down right now. It's in low 70s. Systolically, diastolically in low 50s. The O2 sat is coming down at low 80s. The respiratory rate is going up at 42. The GCS is coming down right now at 8. The progression of the case is not good. The unfolding of the case is going toward the code for a full cardiac and respiratory arrest. The question is, how could we rationally approach this case without killing her? They said intubation when she's still mentating, although decreased level of consciousness, but you cannot intubate her without sedation. With sedation, you lose further blood pressure. Most likely she would code. Giving fluids, well, you raise the legs, the situation is not improving. Positive pressure ventilation decreases preload. With decreased preload, this heart is not going to be any better. With pericardial drain inserted and suddenly large volume fluid is removed, the preload is going to be low. So the cardiac pumping effects is going to be impaired. So the point of this example is to rationally examine every step that you take. That ABCD is not a cliche, it's a concept. A concept that in every clinical situation, its applicability is different. Sometimes when I go to the bedside in ICU, I listen to every breath that my patient takes. I watch every single movement in that face, in that body. I looked and incorporate all vital signs as they dynamically change. And I incorporate them to create a picture, a more complete picture that could help me how to untangle this entangled clinical scenario. And that was a good example. What happened to that patient? So I want you guys to take the challenge and tell me how to stabilize her. You did the physical exam. You heard the muffled heart sounds. You put the central lining, realize the severely elevated JVP. The heart rate is up. The blood pressure is low. The O2 sat is low. The respiratory rate is high. This is getting close to the point of cardiac arrest. Tell me what you would do. Challenge yourself. Think about it. Jump on the traps. This is a safe place to make a mistake.
Dr. Azar, would you want me to
Sorry, Dr. Azar,
pick
what steps have we
one point?
taken so far? Because I haven't been in the session and I've been late. I don't know what sessions we've taken.
We have, sorry, Yashar, I didn't fully understand your question.
I'm sorry for what I asked. I meant just what steps have we taken so far? Because I haven't been in the session and I've
We
been late.
have central line. We put the patient on cardiac monitor. She has a non-rebreather face mask. And we have a dynamically worsening vitals. And we are suspecting, based on physical exam and clinical scenario, I mentioned a few things as well, respiratory crackles in upper fields and lower fields. And we are suspecting pericardial tamponade. Now the question is, I need to stabilize this woman, she's dying. What should I do? They mentioned intubation. We challenged that right now, with intubation, you would lose preload. If this is a pericardial tamponade, she is a preload dependent woman. If there is no blood return to the right heart would fully collapse under the pressure from the pericardium. So rationalize your approach.
Dr. Azar, what about draining the precardial fluid at a slow rate? And meanwhile, if it is going to lose more pressure, raising the legs to increase the preload or administer intravenous volume.
Absolutely. Absolutely. Now you are thinking in case of rationalizing an approach. If I put a pericardial drain, I am not going to take more than 50, 60 cc's every few minutes, every 10 minutes. And together with that, I have the JVP. I know what changes are happening in the central venous system. Now I could temporize to maintain a reasonable JVP. As the pressure around the heart is decreasing and the systolic function improves, and there is more need for more volume, I could moment to moment adjust it. This is a rational approach.
What about inserting Swan-Gaines catheters?
Uh, this is pretty much falling out of favor.
Yes, I know. I've read the articles about that's coming out that Swan-Ganz catheters are not really as useful as they thought to be once.
But even not having access to that, because in Iran, I haven't seen it. Maybe there is one or two centers in the Tehran that may have it, but I haven't seen it in other center. We were struggling for central lines in Iranian ICUs, unfortunately. But in this case, I wanted the rational merit of the case to be examined. Do not go after diagnosis if your patient is about to die. When you are in the process of stabilization, do not go after cliches, A, B, C, D. Incorporate the merit of the case in your approach. Not every unstable airways should immediately be intubated. Consequences of intubation needs to be taken into consideration. Not every hypotension should be given volume. The consequences of volume should be incorporated and assessed. Do I make sense?
Yeah.
Yes, of course.
So please be mindful. Do not follow cliches, follow clinical scenarios. Comprehend the data, incorporate the data, make a rational decision, not a random one, not a cliche one. Incorporate every details of the case. Now, let us find out what really happened to this case. This is what really happened to this case. Because the patient was febrile, one of the colleagues decides to consult the infectious diseases. The infectious diseases comes in, sees the patient, admits the patient to the ward in infectious diseases. That night, patient, the first night, barely stays alive. The day after is Friday. One of the colleagues comes to round for everyone, finds out that hemoglobin of the patient is 8, gives 2 units of packed red blood cell. During the infusion of the packed red blood cells, the patient codes, and the resuscitation was unsuccessful. The X-ray, which was looked at during the medical legal proceedings, made it clear that she had massive pericardial effusion. A week after patient's death, acid-fast bacilli came back positive. That was a TB-related pericardial effusion. It was TB reactivation. Every single step of this case was flawed. Every single step was wrong. 5 times she has been given antibiotics. No improvement. Bronchodilators, no improvement. Infectious diseases starts her on IV ceftriaxone. They take her to infectious diseases ward. So this is, when we looked at the file, I have a file, a medical file, copy of this file. 11 physicians had seen this patient within the first 24 hours of her hospitalization before she coached. In one of the consultations, which I would love you to see, the resident comes and sees the patient. She writes, she's unable to respond to questions because she can't speak. She's so hypoxic. Her O2 sat is 82, respiratory rate is 40. And he walks away. This is 2 hours before she quotes. If you don't see, it's because you are not looking. It's not because it's not there, because you are not looking. Because you have not incorporated, embraced the concepts. Don't do that. Don't do that. Don't follow cliches. Comprehend the rationality of human body, how it works. Anytime you want to make any interventions, ask yourself, what are the implications of this intervention? Almost once a month, they call me with a pregnant woman's arrest during intubation. I had a case just about 2 weeks ago. Why? Because the person who intubates and gives the anesthetics does not understand and fully comprehend how fentanyl and midazolam and propofol are impacting the hemodynamics in a pregnant woman, because they take steps that are not rationalized, because they have lost common sense. The point of this lecture is for you not to ever lose common sense. Ask yourself. The concepts are basic and simple. They are not too difficult. When I don't have enough information, I gather enough information. When the vitals are not complete, I ask for a complete vitals. I assess the complete vitals. When I don't know to judge the situation based on the available vitals, I definitely go after targeted physical exam. So a mind has to be enlightened with rationality, with a common sense. Do not follow the cliches. Do not be so taken away by the diagnosis that you forget about people's lives. A dead person's diagnosis of TB is not helpful. A dead person's diagnosis of any kind is not helpful. I gave you this other example of today. At about 3 o'clock, my secretary said that a patient has come without previous arrangements. He's having left upper quadrant pain. His belly hurts. I said, okay, bring him in. I examined him. I told your colleagues, Yashar, you weren't perhaps part of that. The blood pressure was 240 over 150. He was having left upper quadrant pain and left flank pain. So if I would have just gone blindly after abdominal pain without assessing his vitals, most likely by now he'd be dead. Do not take vitals for granted. Assessing the vitals is in the heart of every clinical scenarios. If I expect you to learn one thing out of the medical school, is to assess the vitals, to measure them and assess them. And trust me, this one thing could make you such an outstanding physician that nobody would die under your care. Do I make sense?
Yes, of course.
One of the colleagues, Tarana, has asked what medication is preferable in pregnancy when we want to intubate a patient similar to this case. There is no differences between pregnancy and non-pregnant people for the induction of intubation. So all medications that are needed are used. I normally use midazolam and fentanyl for induction. I do not like propofol because of his cardiac toxic effects, but it's widely used in Iran. But often I use this fentanyl and midaz. Midazolam is 0.1 milligram per kilogram, but I often start with 2 milligrams, 2 to 3. Fentanyl, normally I start with 50 to 100 micrograms. This is for an average of 70 kilograms person. As the weight goes higher, possibly you would need more midazolam and more fentanyl. However, do not forget, both of them would take away your blood pressure, would take away your respiratory rate. So pre-oxygenation is absolutely critical and essential. Do not forget that. Now,
Uh, Dr. Azar, one question about the patient that you mentioned with abdominal pain. The blood
yes,
pressure is really high, and you mentioned that it was an MI, if I'm right. The
yes, he
right,
was having an acute MI. I put him on a cardiac monitor right there and right
uh,
then. There was an anterior MI in LAD territory. So I used whatever I had in the clinic
Mm-hmm.
and I called an ambulance and I sent him to hospital.
And the
What would
reason
you do?
for the
What
huge
would you
rise
do?
in,
Okay, Ahmed Reza, let me make this to a challenge. This is you and your
okay,
patient. You are in the clinic. What would you do?
uh, I think the most sensible one is call for help first, uh,
Absolutely. I
and
agree.
after that, immediately I would put the patient in a situation that doesn't need the patient doesn't need any more oxygen demand than the usual. Maybe I tell him to maybe lie down, and I try to not.
I lost your voice. Guys, can you hear me?
Ahmad Raza, can you hear us? Yes, of course we can
Now
hear you,
your voice
Dr.
came
Raza. I
back.
think Ahmad Raza, yes, Ahmad Raza's voice, we lost him. Ahmad Raza,
Okay,
can you hear
now
us?
I hear you. I hear you all. There is a question from Dr. Mojibian. Agar az ibtada, if you knew that this is a case of TB, would that make any difference, the medications that you would be given? I think the single most important intervention in this case would have been pericardial fluid removal, pericardiocentesis. As for the medications, I think at this point, by the time that the TB is controlled, you need several weeks' time. By the time that the ATZ, these specific antibiotics, rifampin, and a number of them that we do give for the active TB, I think this is a matter of weeks before we could see any changes in the situation. However, as far as the stabilization, I think if they would have put a pericardial tamponade and relieve the pressure on the heart, if they would use vasopressors to maintain a blood pressure, and then under a very controlled setting, they could give positive pressure ventilation, possibly she would live. I think one of these examples today, Dr. Mujibian, this is a case, it's interesting. Now, if I may, before I go to the next case, I want to finish this discussion with Ahmed Reza. This is a 43
I'm lost.
years old man, 40.
Okay.
Again, Dr. Mujibian says, where was the problem? Well, uh, because these are rare cases, it doesn't occur to everybody. But because there is no rationality governing our way of thinking, unfortunately, it doesn't occur to anybody. The problem is 5 times antibiotics and no results. 5 times bronchodilator, something else. We don't do that. The biggest difference between Western medical system and the Eastern medical system is rationality. And when I think about it, it's not just a medical system, it's the way of life. We do not use logic for majority of our way of life, neither for our driving, nor for our cultural practices, nor for our practice of medicine. But it has to start from some point. And I think medicine is the most crucial point to start from. So please bear this in mind. Think and conduct yourself. Yes, there was plenty. When there is upper airway findings, always TB reactivation should be thought about. Pericardial effusion always should you make think about TB. Frequent antibiotic treatments without any improvement should make you think about TB. The place that patient comes from should make you think about TB. So there is plenty of indications, but for somebody who thinks about it. Now, I want to take this case further of this 43 years old guy with severe hypertension and acute MI in the clinic, not in the hospital, what would you do? Tell me.
Doctors are, sorry because of the interruption. Um, the first thing I would do is ask for help, and after that, I will place the patient in a situation that doesn't need any more demand of oxygen. Like, for example, do not disturb sound, put him on the bed, relaxed, and does not turn a vein for him on the back. After that, spread him immediate oxygen, and also some other medication that could help him overcome this situation. For example, aspirin or such things. This would be
So,
my initial approach.
rationality. Again, Ahmed Reza, rationality. What is happening in this guy's
Okay.
heart? What's happening? What's happening?
Th- I think there is an MI in the right side of the heart.
Ahmed Reza,
The
voice is
right
not
heart
that good. See if you
rhythm.
could correct your distance from the microphone.
Okay. Okay. I think the thing is happening is that the patient right side heart is having a problem pumping the blood, and the left side and the heart as a whole wants to push the blood into the circulation. So there is no problem with the left side. So the peripheral blood pressure, as we measured, is very high, but the right side
No,
couldn't.
wait. Ahmed Reza, wait. The
Okay,
rationality here is impaired. This is an anterior MI. This
okay.
is the LAD territory. Where does LAD cover in your cardiac chambers?
The right side, I guess, the anterior heart is corresponding for the right chamber.
Your right
Um,
heart. Guys,
the
come on.
SA node. The SA node is the first territory that it supports blood to.
Okay. But the question is right now, if somebody's anterior wall is impacted, is that their right heart that is in trouble or their left heart?
The left heart
It's
would be in
mostly the
trouble
left heart, I guess.
because of the preload that is reduced.
Okay, let me now tell you how I would rationally think about that. Number one, LAD covers the left heart predominantly. Your right heart is predominantly covered by the same right coronary artery as well as inferior wall. So the right heart and inferior walls are right coronary artery. The anterior wall belongs to LAD territory and it's mostly left heart. The posterior wall is left circumflex. This is for the beginning. Now, when somebody is having LAD territory MI, ECG changes. This is what I imagine. There is a lesion. If this lesion is in left main, I should have changes in left circumflex. If I don't, the lesion is further down. That lesion obstructs and limits the blood circulation to the left heart. Left heart is ischemic and is crying out loud. So if I use an aspirin and dilute this patient's platelet aggregation, the circulation would improve. Number one. If I could decrease this patient's heart rate, the cardiac demand would increase. That would help. If I decrease the afterload of this patient, I could help the work of the heart and the cardiac demand. So, aspirin, beta blockers, ACE inhibitors or calcium channel blockers, at times nitrocontin, if available, morphine, These are the ways that you temporize the situation. But think about it in terms of rationality, not protocols. This is about rational clinical thinking. Do we agree?
Yeah. And doctors,
And
how would
obviously,
you
you
Yes,
ask,
of
explain
course.
the high blood pressure in this patient?
well, that's a very good question. Let me say what
I,
you guys think.
isn't it a sympathetic reaction?
This is a typical example of catecholamine storm.
Yes, sympathetic
This is
reaction.
cardiac ischemia, which has led to catecholamine storm. His peripheral vasculature is extremely contracted. His heart is beating for its life. Possibly he's at risk of electrical conduction abnormalities. This was a very high risk patient. Normally, patients in this age, they don't survive long enough. I loaded him with almost 600 milligrams. I gave him about 10 80 milligrams aspirin that I have in the clinic. I gave him 4 nitrocontents of 2.6. I had metoprolol, so I gave him 25 milligrams of metoprolol. I have those things in my clinic. I have them. I have just a closet for crisis. And I sent downstairs for morphine, and I gave him 10 milligrams of morphine. By the time that the EMS arrived, his systolic blood pressure was 130. So by a third, it had came down.
Amazing.
And I tried to keep him comfortable by not making him panic. I knew he was next to die, but I never told him that because I think just telling him that would kill him right there. I just told him that take deep breath, be calm, you'll be okay. We'll find a way out. And with this, I just made sure that this catecholamine storm is not getting any worse. And I actually gave him one sublingual volume. I don't know what you call it, diazepam. Now,
Yes,
there
Valium.
was a case today. It reminded me of Dr. Mujibian. I was thinking about her. There was a woman. I will try to summarize this in 14 minutes because at 7:30, actually, my boys and I have an engagement. Uh, there is a 34 years old female, 13 weeks pregnant with Crohn's disease on heparin, low molecular weight heparin that has been started by one of the OBS-GYN's colleagues. Today referred to my clinic. And it reminds me of that case that we managed together with Dr. Mujibian in Mujibian ICU. I think you guys remember, don't you? Do you
If you
guys
could
remember that
explain,
case?
if you could just give us more clues, I think we would remember.
There was a 36 years old female presented with massive rectal bleed. She was at the time 22 weeks pregnant when she came to our care. Dr. Mujibian and I looked after her, and it wasn't easy. Definitely, it wasn't an easy case. It gave us a very hard time. I think she coded 3 times on us. We gave her 51 units of packed blood cells before the discharge. But we were finally able to send her home alive. But the Crohn's disease that she had was refractory. We just couldn't stop her from bleeding. And she was consuming all of her platelets. So often the platelets were in low tens. I remember once the platelets were 4. So it gave us a very hard time. But gratefully, we were able to manage. But this case that today came, it exactly reminded me of the same clinical scenario. The fact that she was anticoagulated really worried me. So I stopped her anticoagulation. And I just decided to follow her outpatient. I am worried when I admit those patients to those hospitals. So many unreasonable clinical decisions are made with severe consequences because, and only because, there is no rationality in our practice of medicine. The common sense is forgotten among us. So the point of this session today was, please, do not ever overlook vitals. Always start your clinical encounter by a complete set of vitals. Before you go any further, make a judgment of the vitals, if they are stable or not. Unstable vitals warrants stabilization, not diagnostic workup. Sometimes diagnosis and stabilization go hand in hand, but often they don't. Do not forget the sight of the overall patient's clinical presentation by having your mind set on one issue. Often this one issue in Iranian practice of medicine is diagnosis. Diagnosis, diagnosis, diagnosis. And sometimes the price of this diagnosis is patient's life. Don't do that. At the time that this 19 years old presented to me, whether it was a TB or not wasn't the first question. How could I stabilize this patient was the first question. ABCD is a concept, not cliche. There is a difference between the two. A cliche is applicable to every situation exactly identically the same way, but concepts need to take the merit of the situation. For every unstable respiratory parameters, intubation is not an answer. For every hemodynamic instabilities, vitals are not, fluids are not answers. You look at the merit of the case, you comprehend, and then before making any clinical decision, always ask yourself, what are the implications of your intervention? How this intervention is going to impact the clinical picture. One of the reasons that we have so many cardiac arrests during intubations, because we are underprepared and we have not questioned the consequences of our interventions. My hope is today's session would bring you back to these common senses. It would bring rationality back to your mind, sometimes taking a few steps back and looking at the forest, not fixated on the tree. The example of a left upper quadrant pain in an obese man in his 40s. If I would look at the trees, if I would not do the proper process, most likely I will send her home with a requisition for ultrasound of the abdomen, thinking that maybe this renal stone, maybe this is an enlarged spleen, maybe this is a peptic ulcer disease. But this question is secondary to the assessment of the vitals and making a decision whether this patient is stable or not. And the stability is not always in the appearance of the patient. Not every time an unstable patient looks unwell. Sometimes their appearance may not give you much clue, but the vitals would not betray you. Check the vitals. Believe in vitals. Now, one thing that could happen, guys, I have a lecture, 2 days clinical presentation in a city called Erdebil. Is there any possibility any of you could come there and record the sessions?
When is the lecture, doctor?
This is in 2 weeks, not this coming weekend. So 20th and 21st of day. So in 2 weeks. exactly in 2 weeks.
Okay. Um, we will
I just
discuss.
wanted to let you know because this is a 2 days workshop on these clinical concepts: stabilization, resuscitation, rational clinical thinking, clinical mind maps. These are the concepts that I will be discussing with the colleagues from that province. Mostly it's Afghan audience and some anesthesiologists and some internists. But if one of you guys could come, would be great. Number one, I could see you because I miss you. Number two, maybe you could record it and maybe you could use it for educational purposes.
Sure, doctor. We
Talk
will
about
try.
yourself.
Okay, for sure. Doctor, one last question. For any newcomers, what would you suggest to increase their common sense and enhance their clinical thinking?
I recommend dissecting one clinical case. Uh, you see, I could take one patient, and I could think about it for 30, 40, 50 hours and not have enough. The problem is you guys are taking so much information without digesting it that it doesn't help. It doesn't help. Rationalize. Take one simple scenario of an acute MI. Rationalize it. Learn the concepts. Don't memorize the protocols. Learn the concepts. That helps your rationality. Do not forget the way that human body works is not a mystery. It's a common sense. By taking a few steps back and looking at the forest, there is so much more that you could get than by fixating on one tree. And we should practice and practice and practice. You need to come to the arena and be challenged. Be challenged. I want us to have these clinical case scenarios. And I want you to speak. Don't be so fearful. Those who fear failing would not learn. Be outspoken, be wrong, make mistakes, be corrected. This is how learning happens. Staying quiet is not going to help you. So please do that. Please for sure do that. We will have every now and then a session called Back to Basics, where we would examine these clinical concepts. I will give you clinical case scenarios, and you should be all over it without any fears that you would make a mistake or you would be wrong or no, not at all. If you don't jump in, you won't learn. And trust me, it's a lifelong journey. I think I learn more than you do. Every day in this clinic, my main job is learning from the patients that I see, from the interventions that I make, from the mistakes that I make. So let us do that. It's almost 7:30. Make a decision about the next week session. Tonight, my boys and I are going to Oshnabia. If you guys remember, some of you came with us. So we have to get on with the drive. For the next week, I don't know if Abul Fazl is here or not. Let me know what uh, you guys want to do. If you want clinical case series, clinical scenarios, there is plenty of them. We could continue. If you want to do topic by topic, remember we chose 10 topics of illnesses. But if you are for now busy with exams, I could do 1, 2 more sessions of conceptual medicines. Later on, these 10 uh, main illnesses in our country, we could start working on those.
Okay, we'll let you
Okay,
know.
sure.
So I wish you all well. I miss you all. Look
Yes, of
after
course. We miss you
yourself.
too.
And if Dr. Mojibian is listening to me, please, Dr. Mojibian, I am going to call you within an hour. If you don't mind, answer my call. I would like to hear your voice. Well, guys, you take the message. Possibly her microphone doesn't work again.
Dr. Mujibian is not with us. I guess I will take your message to her.
Yeah, just take my greetings and let her know that I will call her tonight.
Okay, okay, of course I will.
I wish you all very well, and I look forward to seeing you soon again.
We
Me
do
too,
too. Of
doctor.
All the very best to you for now.
Have a
yes,
good
thank you very
time in
much.
Oshaviye.
Thank you. Goodbye.
Okay, thank you all
Goodbye.
for coming and have a nice night, I guess, whatever it calls.
Thank
Good
you.
night.
Thank you so much.